My name is Dr. Layla and I am going to discuss with you multiple pregnancy. At the end of this course, the student will be able to identify risk factors of multiple pregnancies while taking a history, describe the methods of diagnosis during pregnancy and mention the different presentations, identify the complications in pregnancy and labor and provide advices on how to guard against them. Describe lines of management during pregnancy with details about rest, diet, and tonics. Recognize a plan of the delivery method. List indications for cesarean section. Demonstrate familiarity with the abdominal contour and grips. Definition: it is the presence of more than one fetus in the abdomen of a pregnant woman. According to their number, they could be categorized into twins, most common, triplets, quadruplets. This slide explains the incidence of twins according to Helen rule. The incidence of twins is 180. For triplet 180, 2, for quadruplet 180, 3, and so on. This rule applies for spontaneously occurring multiple pregnancies and not for those induced by ovulatory stimulating drugs. Factors that influence twins: the assisted reproductive technology and infertility therapy are most common cause in modern obstetrics. There are two types of twins: the monozygotic twins where splitting is late and the dizygotic twins where splitting occurs early, and these are the non-identical twins, so the rule is the earlier the splitting the more independent the twin will be. Dizygotic twins are the most common type of twins. They represent 2/3 of cases. It happens when fertilization of more than one egg happens by more than one sperm. They are non-identical, may be of different sex. 2 chorion and 2 amnion. DCDA. Factors affecting dizygotic twins include mainly fertility therapy. Other factors include increased maternal age, higher parity, and hereditary factors on the maternal side. Race may play a very important role. Monozygotic twins has got a constant incidence and are not affected by hereditary factor and not affected by induction of ovulation. Here is a comparison between the dizygotic and monozygotic twins. It will be discussed in detail in the face-to-face presentations. Whether the placenta is 1 or 2 and the amniotic sac is 1 or 2 depends on the time of division of the fertilized egg. Here are the different scenarios of cleavage of monozygotic twins. The earlier the cleavage is, the more independent are the twins. If separation happened between 4 and 80 days, twins will be in the same placenta, but they will have 2 amniotic sacs. Late separation will lead to twins in the same placenta and same amniotic sac. On extreme occasions, division occurs after 2 weeks of the development of the embryonic disc, resulting in the formation of a conjoined twins. This slide will be discussed in the face-to-face presentation. Here is the differential diagnosis of a uterus which is large for gestational age. This slide will be discussed in the face-to-face presentation. This slide will be discussed in the face-to-face presentation. This slide will be discussed in the face-to-face presentation. Ultrasound is the cornerstone for diagnosis of twins as shown in this slide. This picture shows an ultrasound showing the twin peak sign that we'll discuss in the face-to-face presentation. Biochemical tests are not routinely used. We can classify complications into those during pregnancy and those during labor and puerperium and fetal complications. Complications in pregnancy include medical complications, pressure symptoms, antepartum hemorrhage, and amniotic fluid abnormalities. 2 pressure symptoms include difficult breathing, dyspepsia, increased urinary back pressure, and urinary tract infections. Supine hypotension syndrome, increased varicosities and lower limb edema. Fetal complications, more common in uniovular than in biovular twins, in monoamniotic than in diamniotic ones, and in multifetal compared to twin pregnancies. Abortions, mostly due to increased chromosomal anomalies, first trimesteric, uterine overdistension, second trimesteric. Congenital malformations, more common in monozygotic twins, for example single umbilical artery, 7% of twins, 1% of singleton pregnancy. PPROM, preterm delivery and prematurity, the most serious risk. SGA, FGR, and low birth weight. Intrauterine fetal death, IUFD. Twin-to-twin transfusion syndrome. This slide shows complications during labor and their causes. They includes preterm labor, 50%. prolonged or obstructed labor with higher incidence of CS and operative delivery. Law twins. Intrapartum hemorrhage, placental separation. Postpartum hemorrhage, atonic and traumatic. Intrapartum fetal death, see puerperal complications and later sequelae. Include maternal complications as puerperal sepsis, raw maternal manipulations. Social and psychological problems of caring for the newborns, prolonged rest and hospitalization. Increased maternal mortality due to all of the above complications. Neonatal childhood complications. Increased perinatal mortality, higher among monozygotic twins. Possible delayed subsequent development at childhood, may be due to preterm delivery rather than twinning itself. Management of twins include both maternal and fetal during pregnancy and labor and puerperium. Antenatal management include closer follow-up to the mom and to the fetus as shown in this slide. These are the instructions given to pregnant ladies during pregnancy, concentrating on physical rest, reassurance, adequate nutrition, correction of anemia and assessment of the risk of thromboprophylaxis. When we are planning delivery, we should answer the following questions: when to deliver and how to deliver. This will be discussed in the face-to-face session. First 5 causes for cesarean are specific conditions in cases of twins, while the last ones are general indications for cesarean delivery. This will be discussed in details in face-to-face session. Precautions during vaginal delivery will be discussed also in details. Mechanism of delivery will be discussed in details in the face-to-face session. Postpartum management include measures to avoid PPH, guard against puerperal sepsis. Anti-DIG should be given to all non-sensitized Rhd negative women. Psychological and possible financial support. Contraceptive counseling. Care of the neonate. All special conditions will be discussed in the face-to-face session. Twin-to-twin transfusion will be discussed in the face-to-face session. Twin-to-twin transfusion syndrome will be discussed in the face-to-face presentation. Twin-to-twin transfusion will be discussed in the face-to-face presentation. Photos showing donor and recipient twins. This slide on single fetal demise will be discussed in the face-to-face session. Law twins and the vanishing twin syndrome will be discussed in the face-to-face session. Conjoined twin and the twin reversed arterial perfusion will be discussed in the face-to-face session. These photos will discuss in the face-to-face lecture. Try to identify this photo. Try to identify these photos. Various forms of conjoined twins. Differentiation of the type of twins is by sex. If of different sexes, obviously binubular. Placenta. If 2 separated placentae, the twins are binubular. If 1 placenta, may be monubular or binubular. Check for a septum between the sacs by peeling the amnions from each other. Blood groups DNA analysis. HLA antigens. This slide is showing the pre-reading for this lecture. Thank you.